Well, um, good morning or good afternoon in any case, and it's a pleasure to moderate this session. Almost an heresy for three Europeans being moderating a session on ESD update in Europe and Asia. So I have with me my friends Stefan and Sergey that they are well known, and we already organized the session, but I don't want to finish this opening without well, my special acknowledgement also to Professor Inoue, a leader in the field of endoscopy in the world, and also a friend. So congratulations for this meeting, and congratulations to to go through this storm, also organizing an educational event. So without further delays, I will give the word to Stefan, and I hope that you will enjoy this session. Okay, thank you.
Dear colleagues, I also would like to welcome you. And first, I want to thank Haro for this outstanding meeting. And it is now my great honor to introduce Mario Dinis Ribeiro. He graduated from the Faculty of Medicine at the University of Porto, and now he is Senior Consultant and Head of Gastroenterology Department at the IPO in Porto, and he's also guest full professor at the FUMP. And we all know Mario from his outstanding scientific work with many articles on the diagnostic detection and treatment of early cancer changes in the GI tract. And because of his scientific work, he is also co-editor-in-chief of our journal Endoscopy. And he is also our president, the current president of the ASGE. Mario, I'm looking forward to your presentation.
Well, good morning. It's my pleasure and honor to participate in this meeting, the Tokyo Live Global Endoscopy Network, and of course, to address this topic that was proposed to me, hopefully to answer the question of the success of the implementation of ESD in Portugal, but at least I will try to describe it how we did it. This is the summary of my talk. Of course, I will put in context this problem in Portugal. The timeline is the obvious for an implementation process that is going through the phases of learning and building a team to increase the awareness and increasing the referrals, of course, to teach and disseminate, and finally the focus that are the patients. What is the impact that we could observe from this process? And this is the context. Of course, it's not only referring to gastric cancer, but as you know, Portugal has a high incidence of gastric cancer. It's considered an intermediate country for a risk country for this disease. And of course, ESD is not applicable only for gastric cancer, but it's probably the organ where if you want to start and implement, you should start. And we had a chance to do it specifically in Portugal, also because of this. And it is expected. Meanwhile, there is a program for colorectal cancer screening that may lead to more lesions in the colon also, of course. But also during the next years, it's expected that the incidence of gastric cancer, not only in Portugal, but also in Portugal, will not decrease. And therefore, the need, if we detect early the lesions, the need for techniques like ESD to treat and to manage the patients harboring those lesions. Well, everything, or the first procedure was done in 2005. After a fellowship period, you may recognize the building, Toyosu Hospital, exactly the one that is led nowadays by Professor Inoue. And I was supported to stay for 3 months in Tokyo to learn and to attend not only the screening procedures, but also to learn more about the pepsinogen method for gastric cancer screening, but also the basics of ESD, EMR, and ESD techniques with the 2 grants from the Portuguese Society and also from a private foundation in Portugal. It took a while to increase the awareness of this technique, first internally in my hospital, but also externally, and to show the results. The first publication occurred in 2009, and this is an important process of implementing this technique in our region, is to include the metrics, and the metrics were the long-term results were finally published in 2014, where we showed adequate results in terms of survival and also in terms of intermediate results that we aim with this technique, that are an R0 of 94. I will come back to these results later on. The first PhD student finalized his lecture in his thesis in 2019, specifically with a thesis where he stressed not only this, but also this is a landmark manuscript of that thesis, showing that also in a Western population, patients prefer to go for minimal invasive resection versus surgery. Again, the main objective, of course, is to show that this technique was effective, but also to increase the awareness in our region and also in our peer to increase the referrals. Not only that, but also to be able to participate and to bring this technique that first was introduced as an innovative and research technology, but to integrate this in clinical guidelines, and also at the national and international level. And we had a chance to lead the first European guideline on this topic in 2015, more recently the first European curricula, and we are updating the guideline on ESD. Finally, to teach. So we have to learn, and of course you may say, and you may argue, this is a commonplace, that specifically when you are founding a process, you also learn a lot by teaching. And we not only participated in diverse live demos during this 15 years, but importantly, we built a network of courses based in live portions, where we are actually assessing that, and a PhD thesis will probably come from there, and also to build up a network of trainees, and being a training center was definitely important to train others, and to train not only to enlarge the team, but also to train other members, other endoscopists in the country. In our department, as I said, we started in 2005, and after a while the number increased, and now we are 4 endoscopists that we can, even though it's small, there are small numbers for Eastern countries. As I will show, the results are quite nice. Probably, of course, also because of the selection of lesions, but definitely there are numbers that are very important for gastric ESD. And of course, we have other organs that we manage, but this is the focus in our center. The unblocked resection results are 96%, 91% are 0, with a curative resection that is slightly lower than we expected, but I think this is also a consequence of the referrals that I will stress. As you can compare this number with the first that we published 5 years ago, it doesn't mean that we are inadequately performing, but we are the last line before surgery when some patients are referred to us, and therefore the lesions that are treated are finally non-curative at a low rate of complications. Who did we train? We trained 9 centers with different results, different stages of implementation. But overall, it's interesting that most of them attended also courses before and after, mostly live porcine courses. And we have 1 to 2 endoscopists per center. And these are the results. So as you can see, different numbers and different rates of implementation with 1 year. For 50% of the centers took 1 year to implement the technique. The R0 resections and the curative resections are quite relevant, and also a low rate of complications. Of course, the higher number are in the smaller groups. So overall, we have over 1,000 ESDs done in Portugal by the 9 centers that we taught, with 89% of R0s, 83% of curative resections, and 7.5 overall complications. And this is also important to stress that as the network was built, some patients are managed in between centers, and this is ultimately a secondary outcome of this collaboration. Finally, the impact. So we have been measuring, this is for the north of Portugal, and in the north of Portugal, between 2007 and 2011, and if we compare the results, survival results for patients compared with 2012, 2016, and of course it's a 5 years survival rate. We don't have yet data from all these years, but as you can see, it's significant. There is a significant increase, and this may be due because of ESD or minimal invasive techniques, not only ESD but also surgery, but most of all because of early diagnosis. So ultimately, our program that started 15 years ago resulted in a benefit for the patients, and I think this is an important and relevant story that started 15 years ago. As I will say, and I will finish by stressing the need to collaborate. Of course, collaboration inside your institution. First of all, collaborating with the surgeons and with the patients, of course, because you need to state that the first patient will be the first patient. This is applicable to all techniques. Outside your institution, by improving awareness, also going to those hospitals to give lectures and to teach how to diagnose and how to manage the patients. This will increase the referrals. To communicate our results nationally, internationally, and having the chance that we had to influence the European guidelines in this field. And finally, and the ultimate goal is to impact the survival of our patients. Finally, I would like to invite you all, of course, to submit your abstracts to our next ESG days in 2021 that will be virtual. All the abstracts that are accepted will be published in Endoscopy, and of course this will be a worldwide online meeting, so don't lose this chance and submit your abstracts and share your data, and not only about ESD but also about ESD. So we would be very happy to consider your manuscript. Thank you all, and I'm happy to receive questions from you all.
Thank you, Mario, for this very interesting presentation. I think when we look at Europe, Portugal is the only country, and I think this is also thanks to your efforts, where we have national data available from the ESD. My question is now to you, how do you manage this data? Do you have a national database, or how do you proceed with this data from the whole country?
Well, this was a process that we started, and all those centers or all those endoscopists that stayed with us brought to their centers the protocol that we're using. And as you know, aligned with that, the guidelines also mentioned that you should keep records from what you do. So we don't have a national registry, but in all the centers, they keep track of R0 complications and all the results. Of course, we are aware that there are a couple of other centers that were meanwhile developing the technique, of course, learning outside the country and also learning with these centers, but we couldn't, as we don't have the registry, we couldn't track those. Okay.
And another question, if you have a young endoscopist who is very interested in the ESD procedure, what would you recommend him, and what do you think, how many procedures he needs to be confident in the performing the ESD, especially in the stomach?
Yeah, I think there is scattered data about that, and we try to summarize it in our curriculum about that. That was led by Pedro Nunes from our department. And of course, you should start by knowing the technique and knowing the indications, and then visit a center and observe. Of course, being an endoscopist, we always prefer to do rather to observe, but it's fundamental to observe, to take time to observe. And I do think that, of course, if you are able to travel to Eastern countries, it will be better. But also in Europe nowadays, with the efforts that also our dear friends from Japan did during these 2 decades, there are centers that could bring that available. And finally, the numbers vary between 20 to 30 in each of the regions, so that you consider yourself proficient. But more important than the numbers, I would say, are again the results. So it should check your records, and even if you do 12 or 15, but you have 100% R0 and curative resections, those are better than try to have 40, but with poor results. So do properly, select properly the patients, think about the patients first, and then move slowly through the regions, and the proficiency will come.
Okay, thank you, Mario. I will pass now to Sergey.